A long time ago, I also had to speak in the same session as Professor Messer, and that's very nerve-wracking for me. And I got up and I confessed that I was very nervous speaking after the man from Mayo, and I referred to myself as the girl from Gosford. But that was a long time ago, and I can't get away with the girl anymore. So I'm going to talk about what things I try and encourage my patients to do to help them live your best, to live your best life with this disease. And so I'm going to talk about a number of different things. But I actually wanted to start with a quote from a woman called Bryony Scott, whose name may be familiar to New South Wales people. She's a headmistress of Winona School for Girls, and her husband was well known for being the chairman of the ABC. And she was diagnosed with a malignancy, and she said that even when times are tough, things aren't going to plan, or the outcome is grim, we never give up. Hope is not a fairy tale ending, but a gritty commitment to the journey. Hope is engaging in life with every cell in your body. And I think that's what we all want our patients to do. So the things I'm going to talk about today are trying to reduce complications, what you can do to try and minimise your risk of the complications from myeloproliferative neoplasms, the vascular, which is really the arterial complications, the thrombosis, skin cancer. I also will just make a little comment about it because that's very common for us in Australia. And then living with a chronic illness, looking at a couple of alternate therapies, meditation and yoga, and then looking at some psychological strategies. The reason why we worry about thrombosis and hemostasis and thrombotic and hemorrhagic events is because they are very major complications. And if you can get away with just having a TIA and not run into a really major stroke, or if you can get away with having a DVT and not having a clot in your portal vein, you've done well. But clots can be really, really devastating, and they cause a significant amount of the morbidity, so sickness, and the mortality, the death. So we want to prevent these. And they are very common, and this is the incidence in all patients. Thrombotic complications are over a third of patients. So this is from a German registry, it's recent data. So it's really what we see. Hemorrhage is significantly less, but not trivial. So that's why we jump up and down and we say, okay, we've got to think about reducing your risk. And the things that we suggest that people do, and I'm going to have a little bit of a look at them in more detail, is regular physical activity, cease smoking, make sure your blood pressure control is good, what can you do diet-wise, what can you do weight reduction-wise, and limiting alcohol. I'm telling you all of this, I don't necessarily do it all. Okay, so regular physical activity. What that is, and the definition of that, is 30 minutes of moderate intensity physical activity daily. What does it do? It has been shown to lower your blood pressure. It does improve your weight, and it improves your quality of life, and it reduces fatigue. That might sound really crazy, but we know from studies in other cancers, we know in studies in depression, that actually regular low-impact activity improves your fatigue. But not all of us do 30 minutes of moderate intensity physical activity daily. So anything you can do helps. Just sit a bit less and move a bit more. It doesn't matter whether it's gardening, housework, dancing, bowls, whatever you like doing. And incidental activity counts as well. Shopping, going through the shopping centre, walking, all of those things help. Strength training helps maintain core and stability. So really good to do that. We actually tell people to stop smoking, but we're actually not very good at telling you just how bad smoking is for you. Most people who smoke for more than a decade on average lose 10 years of life. It's not trivial. 2 in 3 long-term smokers die from smoking-related disease. It accounts for 12% of all deaths in Australia and a third of all deaths from cancer. So if you smoke beyond 35 years of age, on average, for every year that you smoke, you'll lose 3 months of life. So it is very significant. And we say to patients, it increases your risk of heart attack. And if you have a disease where you've already got a risk of arterial and arterial complications, please don't increase that risk. So it's really important. We know that people who smoke get additional cancers and have a big increased risk. And probably we all know about lung cancer, but actually acute myeloid leukemia and myelodysplasia are on the list of smoking-related diseases. So if we have a disease where there's already an increased risk of leukemic transformation, although we can't tell you that smoking will increase your risk of leukemic transformation, I certainly think that it's possible, and you should be encouraged to stop smoking. There are so many things you can do nowadays to help patients stop smoking. And this talk's not aimed about how you can do it, but just to say, of course there's a mobile phone app, there's a mobile phone app for everything. And nicotine replacement now, it comes in gum and lozenges, in inhalers and all kinds of things. So there's a lot to be done. There's a lot of help you can get if you need help to give up smoking. Because people sometimes look at you when you've told them you've got a cancer, you've got a myeloproliferative neoplasm, these are all the things, and you need to give up smoking. They feel like, hang on, I just want you to stop there. I'm running out to have a quick cigarette and then I'll be back. So we know it's stressful, but it's really important. Getting your cholesterol down. Now, you need to know what your cholesterol is if you've got a myeloproliferative neoplasm. You need to make sure that your GP is checking it. And you need to say to your GP, what should my target be? What should my cholesterol be? This is published everywhere. The Heart Foundation produced these guidelines. And the levels are different whether you've had an arterial problem, so we call that secondary prevention, or whether you haven't. But we would say that patients with myeloproliferative neoplasms who have an increased risk of a vascular complication are sort of like a diabetic person with an increased risk. So we really aim to try and get your total cholesterol under 4, your LDL under 2, and your triglycerides under 2. And you need to ask your GP, what are my lipids, what are my levels, and make sure that they are done. How do you do that? Look, diet, you can get down 10 to 20% to get your cholesterol down, but if you're starting at 8 and you really very strict diet, you're still not going to get to 4. Weight loss, you will lower your cholesterol by losing weight and getting your BMI under 25. But a lot of people who have got a high cholesterol, they rely on medication, and patients look at me and say, I don't want to take another tablet. But we've got to look at the risk, and we've got to think about the risk in the individual patient. And sometimes if that's your only risk factor and everything else is well controlled, we sort of modify what we think is important, but you need to think about it. Lots of people take fish oil, so I've put it up there. Fish oil particularly reduces your triglycerides, not your total cholesterol. And fish oil at a dose of more than 3,000 milligrams has an antiplatelet effect, which means not lowering your platelet number, but stopping them sticking. So it has an aspirin-like effect. So if you're already on aspirin and you're taking a large amount of fish oil, you will bruise a little bit more. Dietary modification. I think we all know this. It means do not eat the chocolate out of your mini bar when you've just come back from dinner. That, everybody, we all know what we should do. Do these things help our blood pressure? And actually they all do, and I've put the slide there, and these slides are all going to be available for anybody who wants to know, but in actual fact you can improve your blood pressure by improving your diet, reducing your alcohol, increase physical activity, reducing your salt intake, reducing your weight. They're all published New South Wales guidelines about what you can do to improve your blood pressure. The other thing that we don't really think about is what can you do about your risk for venous thrombosis? And this is important for patients, and especially for young patients who may not be on treatment other than aspirin or watching for their myeloproliferative neoplasm, their ET particularly. Obesity is a very significant risk factor for venous thrombosis, and a BMI of greater than 30 has a much more increased risk of having a clot in your leg than actually smoking. I don't usually say that, but but that is true for venous thrombosis, so a DVT, pulmonary emboli. They are not particularly related to smoking. Age increases your risk of a clot. We know that. That's how we put people with, how we classify risk in ET, high risk over 60. For young women, oral contraceptive pills increase your risk of having a venous thrombosis. So my young patients who are diagnosed with myeloproliferative neoplasms, I talk to them all about what we're going to have for contraception and encourage them to come off a combined oral contraceptive pill. If there are issues, we look at what can be done, we look at progesterone-only options, but we certainly avoid the third generation, more modern oral contraceptive pills because they've got a higher risk. So there are lots of things you've got to be on your toes about. HRT increases your risk of venous thrombosis. Pregnancy increases your risk. And in fact, so for tired males who think a bit of testosterone might pep them up, that also increases your risk of venous thromboembolism. So there are lots of things you've got to think about and be proactive about. And particularly when you go into hospital to have something else done and you might think, my ET's fine, it's not really a problem, I'm just having an arthroscope. But your surgeon needs to know you've got ET. You need to say to them, I've got an increased clotting risk because hospitalisation, surgery, immobilisation, if you do something to your leg and you end up in a plaster or a boot, you would need to have Clexane or a preventative to stop you clotting. So you need to be thinking about these things. You need to be making sure that the ED person knows that when you go to ED with your ankle problem, that they know about your myeloproliferative neoplasm. And if they look a bit vague, that may be because you're the first person they've ever seen with ET, and that you say you need to call my haematologist and get some advice. Okay, skin cancers. That is a very big problem in Australia for our American friends. 60% of people over the age of 60 have had a skin cancer. When we tried to have a look, which I did some work a long time ago with Professor Grigg, we tried to look at skin cancer in our patients with myeloproliferative neoplasms and determine if there was an increased incidence. There probably is from the disease itself, but we know that hydroxyurea further increases that risk of skin cancer. So you need to be very proactive at avoiding it. You need to be thinking about appropriate clothing, hat, shade, sunscreen, all of the slip, slop, slap stuff that we know about. You do need to also be aware that there's a small signal in the polycythemia vera, ruxolitinib, that may also have increased risk of skin cancer. When we say a small signal, like a little bit of an incidence more in people on ruxolitinib in that one study. So the jury's still out. We don't know about that, but I think it's really important and people to be very proactive about having your skin checked either by your GP or your skin cancer clinic or whoever you feel comfortable with. I always think I need to give you a little bit of good news. So in fact, there is a publication, which I've referenced down there, that suggests that aspirin may actually reduce the risk of skin cancer. So all that aspirin that you take may actually do something beneficial, and it is accepted that it lowers the risk of GIT cancer quite significantly. So living well. Well, I do feel that we're a bit guilty sitting up here telling you about how to live with a myeloproliferative neoplasm when I don't have a myeloproliferative neoplasm. I can't actually be quite so certain about David Ross because he put himself on my database as a test case and he's never actually taken himself off. So I just wonder if he's sitting in the front row taking notes for a reason. So we know from the fabulous work that Professor Messer has done that we have a lot of symptoms, or patients have a lot of symptoms that impact on their quality of life in myeloproliferative neoplasms. And you've seen the data already today, that the symptomatic burden that patients with myeloproliferative neoplasms have is significant, that fatigue in 88% of patients, and that compromised daily function is common. We know that there is a reduced quality of life, and we know that patients with myelofibrosis have the most significant symptoms. And more recent work as well done by Professor Messer's group has shown that the sexual dysfunction in patients with myeloproliferative neoplasms is common, and that it is severe sexual dysfunction in a significant number of patients. And that is particularly a problem for people who are aged over 65, for people who've got low blood counts, for people needing transfusion, and for people on certain kinds of therapy. So there's lots of symptoms that you are putting up with and dealing with on a day-to-day basis. And when we think about chronic illness, we know that there's the illness-related factors, that there's the potential life interruptions, there's the psychological changes that go. So knowing where all of those things that are going on, how do we actually help you live well? How can we, be proactive in managing your own health? So that's what we want you to do. We want you to be able to understand the risks, look at what you can do to minimise those risks. It needs to be holistic. It does need to be thinking about diet, thinking about exercise, thinking about making sure everything is as good as it can be. Because all of us here as doctors want our patients to have an active and fulfilling life. We can't take away what's happened, but we have to go forward and make things as good as possible. So we have to deal with the physical and psychological issues of chronic illness. And we know that involves dealing with the frustration, the fatigue, pain, sometimes the isolation of your diagnosis. We want to encourage you to exercise because we really do think that is good for fatigue, and it does help maintain and improve your strength and flexibility and endurance. And the other thing that unfortunately you have to do is you have to be able to interact effectively with the people who care for you from a healthcare professional. You have to make sure you're able to communicate with your haematologist, that you are able to use your medications and manage your side effects. We can't take away the side effect. You won't get a side effect if that tablet stays in the jar or that needle with the interferon doesn't go into your tummy. But if you're going to have medication, they are going to have side effects, and we need to manage them. And we need to be able to work as a team to evaluate and negotiate the therapy that is best for you. So I'm going to talk about meditation, and I'm going to talk about yoga. And there are some people in the audience who are much better informed about meditation and yoga than I am. But my son tells me that meditation is fabulous, and he keeps saying to me, "Mum, when you've got a minute." Well, when I've got a minute, there are a lot of things to fit in that minute. So, in fact, meditation has been looked at fairly formally to see what benefit it offers. And there are actually 47 trials that could be found that were of a quality that could be looked at and all pooled all this information. And there were 3,500 plus participants who had contributed to the data on meditation. So mindfulness meditation does show that there is evidence to say it improves anxiety, depression and pain, and a little bit less robust evidence to say it improves stress, distress and mental health related quality of life. Not much benefit probably if we're trying to treat substance use, eating habits, sleep and weight with meditation, but some good things that can be done with meditation. Many of the studies don't really collect the information on how religious people were about performing the meditation, how much instruction they had. So they're always a little bit soft from that point of view. But there are studies in predominantly breast cancer, predominantly women, obviously, and that has been shown to improve anxiety, stress, fatigue, general mood and sleep disturbances. So in fact, there is a meditation coach with an MPN sitting in this audience. He's very keen, he's in Melbourne, and he's very happy to teach meditation to anyone with an MPN free of charge. And I have suggested to the MPN Alliance that next meeting they have lunchtime meditation run by David. You could put your hand up and wave there. So they can have lunchtime meditation. And in the other room, we'll get Professor Messer back to teach us all yoga. If he's not overly keen on teaching us all yoga, then there is somebody else in the room who's very good at yoga who probably won't want to put her hand up. She'll look daggers at me and be finding a new haematologist. Down the back over there, yes, Natasha, who also does lots of yoga. And you've seen the yoga data about what yoga does, and most of the studies have been in breast cancer patients, and they have shown it decreases fatigue and it decreases insomnia, improves symptoms of depression and quality of life. And then, of course, there's Professor Messer's data as well, which he has shown you. So I think there are things that you can do that can help. But in my last few minutes, and I'm looking at Anne because I've got to think how many more minutes have I got, because I've got 5, perfect. I have read some information from the Let's Feel Better website about living with a chronic illness. And I think Alana has a few messages that are really quite good. Now, she doesn't have a malignancy, but she certainly has a debilitating chronic illness. And she does say that it is important to balance, to not spend all of your life hunting for why. Why did I get this illness? Why is it making me feel like this? What is the best solution? She said, some days you have to get up and say, how am I going to handle living with my disease and the symptoms it causes today, and move forward, because there isn't always an answer to the why. And that you do, to live well, need to at some stage put that aside and live, not continually search for answers, or search for answers that we may not actually have an answer. She also makes a big point about working. And I think this is very important, and I feel quite strongly about that. It depends upon what you think about work. Most of us, when I say work, think about employment. And yes, that is one aspect of work. But working on your goals, working on what you want to achieve in life, that is all work. Paid work outside has clearly been shown to be good for health and well-being. It's good for people's self-esteem, and not being able to work impacts negatively on your health. So what we want patients to be able to do is look at how they can work if they are still working with their disease. That might be part-time work, that might be working from home, or it might be working on goals. Learning Spanish, like my crazy 17-year-old daughter. She's not learning physics, which she's doing in the HSC. She's learning Spanish, which she's not doing in the HSC. But whatever your goals are, whether it's learning another language, learning a skill, doing something with the grandchildren, working on a goal really gives you purpose, gives you self-esteem, and is a good thing. The other point she makes is that if you are struggling with treatment, if your body is one of the ones that makes interferon an incredibly horrible challenge, or if, in fact, Ken and his talk, luckily Ken has had every complication, side effect and problem that you can ever hear of, so I don't think anybody else here will ever have a mouth ulcer from Hydrea, because he's had it all for you, so don't worry. But if you have problems, it's not your fault, and hating yourself, hating your body, hating your symptoms doesn't do you any good. You need to understand that it's not your problem. You don't need to hate yourself. You don't need to reject yourself. You just need to move forward in how you can accept how things are, change the things that you can change, some things you can't change, and get on with the fact that you have a myeloproliferative neoplasm and I need to live with this disease. The other comment she makes is not to spend too much time fighting your disease. And she says we need to deal with it, but we don't need to fight it, beat it, make a voodoo doll out of it, stab it to death with acupuncture needles, because that won't get rid of it. We need to treat it, we need to deal with it, and move on. So her phrase was, don't headbutt your disease, outsmart it. And she also encourages everybody to move. She says, yes, when we get knocked off our feet with a diagnosis when we're trying to go camping at Easter, or whatever else you might be doing when suddenly out of the blue somebody tells you there's something wrong with your blood. We know that that's the shock, that you're stunned and just can't move forward. But we want you to get over that and then get moving. And it doesn't matter if the moving forward is slow or only in tiptoey steps or baby steps, that you need to move forward, get out of bed, get up and achieve something, because that's how you will live the best possible life you can with it. And because you're all going to be living well, you want to travel, and absolutely travel. You should try and out-travel your doctor. And a few tips for what you need to do, that make it easy. Make sure you've got all your medications when you travel. Take a copy of your blood count. So if something unexpectedly does happen, that you go somewhere, it's very easy if you've got a copy of your blood count and your last letter from your haematologist. And that's much easier if you ask them, as you're going out the door and there's, standing room only in the waiting room, oh, I need a letter for travel. But actually taking the last letter that they've written is usually up to date, got results, treatment in it, those kind of things. Make sure your vaccination requirements, ask about that before you travel, and make sure that you notify your travel insurance company of your MPN diagnosis. Oh, and in fact, there's YouTube's some fantastic things, and I will look forward to seeing Ken on YouTube. But Professor Messer, possibly a year or two ago, he has top 10 tips for battling fatigue, and I've put them up there about things that you can do to battle fatigue. And when all else fails, talk to your haematologist, because we're actually there for the ups and the downs of life with you. And so I thought I started with a quote from Bryony Scott, and she talked about, living and having hope and moving forward. And in her article, she did have a little comment about doctors. She said that doctors are funny souls. I'm not sure if that's good or bad, but she did say they have hope. They believe in the human spirit to take on the big challenges and to give life its best shot. And I think that that's probably why we're all here, because we want you guys to be able to do that well and effectively and live the best life you can.